There's already lots of studies showing that we could use virtual reality with anxiety disorders. VR can be used with people from specific phobias, and the key ingredient that you might be aware of about any treatment that is really documented as being effective treatment for anxiety disorders, at some point you need to confront your fear, what we call exposure. So virtual reality can be used to do exposure. If you're afraid of snakes, you can have a virtual snake, and the patient can progressively get closer to the snake, to appraise the snake, to realize that the snake is not as dangerous as expected, and they can cope. And it's very useful for the therapist because you don't need a snake in your lab, which is kind of cumbersome. So it possesses some advantage over in vivo exposure. One is the availability of stimuli, the safety for fear of heights, for example, the cost for fear of flying. There's a long list of advantages compared to in vivo. And there's more than 60 studies that have been done with specific in vivo exposure for specific phobia. It is very interesting scientifically to use specific phobias to run outcome trials because these are simple cases. So you don't have to deal with comorbidities. So you know what you're dealing with. The treatment is pretty straightforward. It's essentially exposure. You can do that in 8 sessions. You know what you're doing. And you can compare in vivo and in virtual reality. You can compare both. So the snakes, the spiders, you can have the virtual stimuli and the physical objective stimuli. You can have really good treatment. So scientifically it's very interesting because we know what we're dealing with when we do exposure. But clinically it's boring. I don't know how many of you have seen many cases of snake phobics in your career. Some people are saying yes, but because you're working at UBC, anxiety disorder clinic, maybe you know some of them. But it's the same for me because we're an anxiety disorders clinic in Holland, Gatineau. But otherwise, people don't see that many specific phobics. What we see are complex cases of anxiety disorders like PTSD, SAD, OCD, panic. This is where we really need the technology to help us. Because most people will tell me for this fear spider environment, why bother with virtual reality when I can get a spider in my lawn outside? So scientifically it's useful, clinically it's not as interesting. But now the field has moved and evolved. If you look at the meta-analyses, there's more than 50 to 60 studies looking at VR for specific phobias, and now we are addressing the real complex cases. So I'm just making the case of Rothbaum et al. Studies in 2002 because it was one of the groundbreaking studies that really documented the use of VR for specific phobia. I'm sorry if I'm moving. It's a challenge for the camera. And Paul Emelkamp in the Netherlands, just to show that there's studies done in the States, there's studies done in Canada, there's a few studies in Canada, and there's studies done in Europe and elsewhere that have been documented the efficacy of VR. But the real interest is for complex cases. And this is where we're heading today. Okay, the first study. I want to mention the study about virtual reality for social anxiety disorders. This is a randomized controlled trial we did in our lab. It's the SHRC and CIHR funded study where we have 54 participants that were randomly assigned to one of 3 conditions. So we had the first standard controlled treatment, which is CBT, cognitive behavioral therapy, and the patient would come to the clinic and receive individual CBT once a week with only in vivo exposure as the exposure component. So we had the cognitive structure and all the other ingredients that you would have in the CBT package, but when it was time to do exposure, we did only exposure in vivo. Okay, I'll give you a few pictures to illustrate that. The second study, or the second group, was CBT plus VR. So essentially the same manualized treatment, but once we moved to exposure with only exposure with virtual reality. We put the goggles on, I'll show you screenshots, and we do the exposure only with virtual reality. And the third group, as a control group, is a standard waiting list control group. Post-treatment, because you have to do something with the poor folks in the waiting list at the end of the treatment, you don't just send them back home. Their participation in the study was done, but at the end of the treatment, we decided to take those patients, get new data again, and the therapist, well, we gave them free treatment for the patients in the waiting list. And the free treatment was that the therapist could do whatever they want. So they could combine. They were not struck with the contingencies of a randomized controlled trial. The therapist can combine whatever they want. Do some in vivo, some in virtual, and go back to in vivo. So I'll show you the studies with this group as well as the combined one, which is probably what you would do in clinical practice if you're not struck with an RCT. Mean age, 34, if you say mostly females. The recruitment was in the psychiatric hospital in the city downtown. All were skip diagnosed, and we can go on with the details of that study. But here's a quick look at the results. This is the inhaler. Yeah. So we have the Leibowitz self-administered French version, and the red line is the cutoff score for the clinical and non-clinical range. And what you have in pre to post, and post to 6 months follow-up, we'll finish at 12 months follow-up now. But the waiting list, no significant change, or we're stable. If you look at virtual reality and standard CBT, you see a significant difference from pre to post. These are the results for the statistical results. Pre to post and results were maintained at follow-up. And what you would see is the interaction. The interaction is not significant, and we did a statistical test for non-inferiority, and we can say that it's statistically non-inferior, meaning that it is equal in terms of efficacy. These are a few screenshots of what we did. This is the in vivo exposure. If you know your CBT a little bit, you know that social phobics are not afraid of people. They're afraid of ridicule. It means that when you do exposure, you need to expose them not only to people, but to ridicule. So that's an example of myself in a therapy with a patient. That's me wearing a mosquito hat. That's my patient wearing a blue Mexican hat. The two of us on a urinal in the male bathroom actually having sex jokes while people are waiting behind us. That's the kind of things you would have to do. You purchase condom at a grocery and asking for a route to try the size, kind of stuff we do in vivo. So actually you're dealing with ridicule, which is sometimes a deterrent for some of the therapists. This is actually also another patient doing the exposure in the class. That's what in our lab. So this is myself, this is the patient, and this is the staff. So I would gather the staff and having them sit around, and then the patient would come, pick up out of a bag, pick up a topic that they have to talk without being prepared for 5 minutes in front of the group, and progressively increases the challenges of the talk. So initially they could talk about their life. Then you can talk about social phobia, which is kind of recursive because you talk about how bad you feel when you're social phobic in front of people. And then you can talk to more complicated complex, for example, the sexual reproductive habits of ants in North Pole and their impact on hippopotamus in Australia. You have 5 minutes to talk about that. Which is kind of complex. Or you do the same in virtual reality. So that's myself with the goggles on. And then I could go to the grocery store. I could return a pair of shoes that I don't like. I have to deal with the cashier. I could go have a drink with friends. I could go to my parents-in-law and actually discuss with them with the goggles on and do the exposure. It's much more simple for the therapist. These are the results for the combined treatment. If you look at the combined, remember that this is pre, but it's actually post from the waiting list. And then they were receiving the treatment as the therapist would like. And this is their post compared to the real post of the other two groups. And what you see is no significant difference in terms of interaction. All treatments are effective, that's what we expect. And then we might also assume why VR would be more effective if we do the same thing in vivo and we do in virtual. And that's another problem we have. I'll come back to that in the discussion. But if you do the same thing in virtual reality that you would do in traditional therapy, you would expect to have the same efficacy. Which makes sense, that's quite interesting, but then again, why bother with VR? If it's as effective, well, let's take the old traditional treatment. Well, we also developed this scale, which is the acronym is the sweat. How much sweat you put in therapy. Specific word for exposure applied in therapy. So we recorded how much effort the therapist would spend to the treatment in terms of cost, in terms of preparation, in terms of ridicule for the therapist. I don't know how many of you would like to go to the male bathroom wearing a mosquito hat, but these are kind of things that you could register. And this is the scale from the sweat. This is the CBT, and the CBT with the combined one, and this is the VR virtual reality. And what we found was, although the treatment was as effective, it's significantly less sweat for the therapist. Which is interesting for you guys. It doesn't change anything for the patient. But you guys don't have to do those silly things anymore because then you can actually do exposure in virtual reality. So I can go through all the scales, but essentially what you have is less issue with confidentiality, less issue with costs, more easy to get the stimuli, and so on. And it's quite interesting, for example, if you're working with children suffering from social anxiety, because it's becoming difficult to gather a crowd of other children where you can be exposure, whereas with designing virtual crowds for children in VR, which actually been trained and tested here at UBC with Miller, and you can do the exposure, but it's even more gains for the therapist when we're talking about school social anxiety. Okay, so I'll come back in the conclusion, but that's an example for social anxiety when you can interact with avatars. We saw avatars in the first talk, and then the avatars can actually laugh at you. That's what happened in the virtual reality. Now let's look at obsessive-compulsive disorder, OCD. In OCD, there's very few studies doing VR and OCD. There's actually only one group, and this group is led by Sun Kim and Jong Hong Lee in Korea, and what they're doing essentially is using checkers. And you have to go in this environment, and you have to turn the stove on and off, and then check the doors, and then they let you in this virtual environment, and then you have time to spend in the environment. And they realize that OCD participants are checking more in this virtual environment than they would do in an art environment, and they would do in normal controls. It's surprising because somehow you don't care about a virtual environment that could burn because it's virtual. So even if you don't check the virtual stove, who cares? Because you just turn the goggles off. But this is now how people think when they get in a virtual environment. And this is something that will come up in the discussion as well. So they did a few studies, and progressively they had a few things, and they compared OCD and OCD subtypes.